Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 476 of our pharmacotherapy series, which majors in hematopoietic cell transplantation. The next case reads: KTM is a 36-year-old woman with chronic myeloid leukemia in accelerated phase. After her initial diagnosis, a successful search for an unrelated 6 out of 6 human leukocyte antigen-matched allogeneic donor was conducted. KTM is being admitted for myeloablative allogeneic peripheral blood progenitor cell transplantation. Orders for KTM's preparative regimen are written as follows: Busulfan, 16 mg per kilogram total dose to be administered over 4 days, 1 mg per kilogram per dose orally every 6 hours for 16 doses, days -7, -6, -5, and -4. Cyclophosphamide 60 mg per kilogram per day IV to be administered on days -3 and -2. Day -1 is a rest day, followed by infusion of peripheral blood progenitor cell on day 0. So my next questions to you read: what toxicities associated with myeloablative preparative regimen should be anticipated in KTM? Are they similar to those anticipated after standard dose chemotherapy? Myelosuppression is a frequent dose-limiting toxicity for chemotherapy when administered in conventional doses used to treat cancer. However, because myelosuppression is circumvented with hematopoietic rescue in the case of patients receiving hematopoietic cell transplantation, the dose-limiting toxicities of these myeloablative preparative regimens are non-hematologic, i.e., extramedullary, in nature. The toxicities vary with the preparative regimen used. Most patients undergoing hematopoietic cell transplantation experience toxicities commonly associated with chemotherapy, such as alopecia, mucositis, chemotherapy-induced nausea and vomiting, infertility, and pulmonary toxicity. However, these drug-related toxicities are magnified in the hematopoietic cell transplantation population. In addition to her preparative regimen, the following supportive care agents and monitoring parameters are prescribed for KTM. On the day of admission, day -8, administer levetiracetam 500 mg orally twice daily from days -8 to -3. Busulfan pharmacokinetic blood sampling is to occur after dose 1 to a target busulfan concentration at steady state, abbreviated as CSS, greater than 900 nanograms per milliliter. Begin normal saline hydration 3000 ml per meter squared per day 4 hours before cyclophosphamide and continue for 24 hours after the last cyclophosphamide dose. Mesna is to be given concurrently with cyclophosphamide as 10% of the cyclophosphamide dose administered intravenously 30 minutes before starting the cyclophosphamide dose, then as 100% of cyclophosphamide dose administered as a continuous IV infusion for 24 hours after each dose of cyclophosphamide. Beginning on day -5, weigh patient twice daily, check fluid input and urinary output every 4 hours, and monitor urine for RBCs daily until 24 hours after the last cyclophosphamide dose. If urine output drops below 300 ml for 2 hours, administer an IV bolus of 250 ml normal saline and give furosemide 10 mg per meter squared, not to exceed 20 mg IV. My next question to you reads: what is the rationale for these supportive care therapies and monitoring parameters prescribed for KTM as they relate to busulfan therapy? Seizures occur in approximately 10% of patients receiving high-dose busulfan in hematopoietic cell transplantation preparative regimens. Busulfan is highly lipophilic and readily crosses the blood-brain barrier with an average cerebrospinal fluid to plasma ratio of 1 or higher. Seizures are probably a direct neurotoxic effect, therefore, seizure prophylaxis is used. Many hematopoietic cell transplantation centers have moved from phenytoin to levetiracetam for seizure prophylaxis, although benzodiazepines, e.g., lorazepam or clonazepam, also have been used. Seizure prophylaxis is started at least 12 hours before the first busulfan dose and is usually discontinued 24 to 48 hours after administering the last busulfan dose. Seizures can occur despite the use of seizure prophylaxis, but they usually do not result in permanent neurologic deficits. My next question to you reads: what dosing strategies can be used to minimize busulfan toxicities? Intravenous busulfan is commonly used in combination with cyclophosphamide as a preparative regimen before allogeneic hematopoietic cell transplantation for chronic myeloid leukemia. The FDA-approved dose is 0.8 mg per kilogram IV every 6 hours for 16 doses, which is similar to the oral busulfan dose of 1 mg per kilogram, assuming a fraction absorbed of 90%. Intravenous busulfan, at 0.8 mg per kilogram of actual body weight, produces an average AUC of 1,200 micrometers per minute, within a wide range of 900 to 1,500 micrometers per minute in 80% of patients. Higher AUC values, that is greater than 1,500 micrometers per minute, have been associated with an increased risk of developing veno-occlusive disease, abbreviated as VOD, of the liver. Therefore, monitoring of busulfan AUC is warranted. Target AUCs are commonly between 900 and 1,350 micrometers per minute after the first dose. This minimizes the risk of veno-occlusive disease and graft failure and minimizes the risk of disease recurrence. To minimize adverse events from IV busulfan, an AUC is obtained with the first dose of busulfan to analyze KTM's exposure. Samples are drawn at the end of the 2-hour infusion, then 1, 2, and 4 hours after the first sample. Many centers are not capable of analyzing IV busulfan levels. Therefore, prior arrangements must be made for timely analysis of these samples in order to adjust the dose after the second or third dose, if needed. KTM's AUC comes back 12 hours later at 1225 μm per minute and, therefore, her dose is not changed. Had the AUC been greater than 1350 micrometers per minute, her dose could have been adjusted using the following formula. Adjusted dose, in milligrams, is equal to actual dose, in milligrams, times target AUC, in micrometers per minute, divided by actual AUC, in micrometers per minute. My next question to you reads: what is the rationale for these supportive care therapies and monitoring parameters prescribed for KTM as they relate to cyclophosphamide therapy? In hematopoietic cell transplantation patients receiving cyclophosphamide, moderate to severe hemorrhagic cystitis occurs in 4% to 20% of patients receiving hydration alone. Development of hemorrhagic cystitis is thought to be due to the bladder toxin acrolein, a metabolite of cyclophosphamide. The chemoprotectant Mesna donates free thiol groups which bind acrolein and reduce its toxicity. The American Society of Clinical Oncology, abbreviated as ASCO, guidelines for the use of chemotherapy and radiotherapy protectants recommends the use of Mesna plus saline diuresis or forced saline diuresis to lower the incidence of urothelial toxicity, with high-dose cyclophosphamide in the setting of hematopoietic cell transplantation. It is important to note that hematuria or hemorrhagic cystitis can occur despite the use of any of these methods. The optimal Mesna dose with high-dose cyclophosphamide in preparation for myeloablative hematopoietic cell transplantation is unknown. A variety of different regimens have been used, including intermittent bolus dosing, Mesna dose 20% to 40% of cyclophosphamide dose, administered for up to 5 doses, or continuous infusion regimens, Mesna dose 80% to 160% of cyclophosphamide dose. Mesna should be continued for 24 to 48 hours after the last cyclophosphamide dose, such that Mesna is present within the bladder at the same time as the urotoxic metabolite acrolein. After IV administration of Mesna, most of it, i.e., 60% to 100%, is excreted within the urine over the course of 4 hours. Cyclophosphamide has an average half-life of 7 hours after administration of 60 mg per kilogram. 100 and acrolein may be present within the urine for 24 to 48 hours after cyclophosphamide administration. Thus, KTM is receiving hydration with normal saline and Mesna, administered as a continuous infusion, to minimize her risk of hemorrhagic cystitis due to cyclophosphamide. KTM should be monitored for any RBCs present in the urine, along with her urinary output, to allow for rapid intervention if hemorrhagic cystitis occurs. My next questions to you read: what other end organ toxicities must be watched for? Should any medications be ordered for KTM to prevent and treat the gastrointestinal effects associated with myeloablative therapy? The high doses of chemotherapy in preparative regimens cause most patients to be nauseated and anorexic until day +10 to +15. Chemotherapy-induced nausea and vomiting in hematopoietic cell transplantation recipients can be due to highly emetogenic chemotherapy agents, total body irradiation administration, and poor control of nausea and vomiting prior to hematopoietic cell transplantation. Thus, patients such as KTM who are undergoing a myeloablative hematopoietic cell transplantation should be given prophylaxis with a serotonin antagonist plus a corticosteroid. American Society of Clinical Oncology guidelines state that the use of the neurokinin receptor 1 antagonist, aprepitant, should be considered, although evidence to support its use in hematopoietic cell transplantation patients is lacking. Because aprepitant is a moderate inhibitor of cytochrome P453A4, it may theoretically interact with the preparative regimen, especially cyclophosphamide. Well-controlled studies evaluating its efficacy, along with its potential for causing drug interactions, are needed. Some data suggest that the serotonin antagonist ondansetron may increase cyclophosphamide clearance in patients undergoing a myeloablative hematopoietic cell transplantation. However, further work is needed to identify the clinical implications of this finding because, to date, cyclophosphamide concentrations have not been consistently associated with clinical outcomes in patients undergoing a myeloablative hematopoietic cell transplantation. Most patients receiving a myeloablative preparative regimen may also experience mucositis due to its effects on rapidly dividing cells of the oral epithelium. The use of methotrexate as graft versus host disease prophylaxis also contributes to mucositis. Oral mucositis may also contribute to the development of nausea and anorexia. In severe cases, parenteral opioid analgesics for pain relief and total parenteral nutrition may be needed. Because mucositis can be worsened by superinfection, good oral hygiene should be practiced. Soft toothbrushes should be used and replaced often. Oral mucositis can be decreased with the use of recombinant human keratinocyte growth factor palifermin. The Multinational Association of Supportive Care in Cancer and International Society for Oral Oncology guidelines recommend palifermin to prevent mucositis for patients with hematologic malignancies receiving myeloablative chemotherapy and total body irradiation with autologous hematopoietic cell transplantation. Palifermin 60 micrograms per kilogram per day is given for 3 days immediately prior to administering the preparative regimen and for 3 days after infusion of the hematopoietic stem cell graft, i.e., days 0, +1, +2. In these patients, palifermin lowered the incidence and average duration of clinically meaningful oral mucositis. The incidence of blood-borne infections and the use of parenteral opioids were also diminished in patients using palifermin. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 477.